series of chat. Yes, this meeting is being recorded, and if anyone has a problem with that or doesn't want to be included, please email the chat directly, and we'll figure this out. So yes, in case for everyone who doesn't know, CHAI is the Causality in Healthcare AI Hub in the UK, and one of the goals of the CHAI Hub is to bring the community and the people around of causal AI together. So like this seminar series acts like a platform where we aim to provide like a solid place for knowledge to be exchanged and beautiful and meaningful discussions around cutting edge research and causal AI could spark across multiple different fields and disciplines. So this seminar series runs every month, but I have to warn you though the next month is July and we're gonna have a pause, so we're gonna start again in August. This session is being recorded, so I'm looking at my notes. And but before I introduce today's speaker and today's talk, first I will have to give the floor to Brooke Lehman from University College London, who and from the data science will talk us about the data science for health equity initiative and how we can build the world where data improves everyone's health. So without further ado, thank
I think you're muted. Yeah.
Of course I am. Thanks for the intro, and I'm just going to take maybe 3 minutes of your time to introduce you all to Data Science for Health Equity. So Data Science for Health Equity is a community for people working at the intersection of data science and health inequalities. So that might include data science. We're defining very broadly. So causal AI, very much data science. And so if you're interested in health inequalities or already working in health inequalities, then we would love to have you as part of our community. We're a broad church. We have about 3,000 people within our community, spanning academia, healthcare, policy, and the private sector. What do we actually do? So similar to some of these activities, we host a bunch of virtual meetups. We have our monthly download, which is just a friendly discussion. We have a very active Slack workspace with almost 1,000 members. We'd love to get to 1,000 over the next month or so, where people can ask questions, post opportunities for funding or jobs, or just connect with others in the community. We also have a library of articles and tools and resources that are shared within our Slack workspace that we keep track of. And lots of events, so lots and lots of webinars. We've hosted workshops in the past and hackathons, and much more to come. Our activities are centered around our themes. We have 6 themes at the moment, including a new one on data diversity. The ones that might be particularly of interest to those here are data diversity and also statistical methods. These run a bunch of kind of like independent activities, which really vary depending on the theme. So the best way to learn more is to go to our website, which I'll point to in a second, and you can learn more there. Easiest way to kind of stay up to date with what we're doing is to subscribe to our newsletter. I'll post a link in the chat, and if you go to our homepage, you can just click on the subscribe to our newsletter, and you'll get a monthly email, nothing more. If you want to subscribe to theme-specific mailing lists, you might get a few more emails, but that's the best way to kind of stay up to date. You can also join our Slack, as I said, very active, and you can follow us on LinkedIn, where we also share some of our blog posts. Don't want to take out any more of your time, so yeah, thank you for your attention. I'll stop sharing, and I will post the links in the chat in a second. Thank you, panels.
Excellent. Thank you very much. And now we shall move on to today's main speaker, Dr. Eliana Vasquez from University of Manchester, who will give us a talk on how causal analysis can help improve radiation cancer treatment. So, yes, I think we can start.
Thank you very much. Let me just share the screen. I hope you can. I think you're seeing my screen right now.
Yes, it's excellent.
Perfect. So before I start, I want to introduction about my background. I'm a computer scientist. Been working in cancer therapy research for many years, like around 20 years now. And I have been doing a lot of image registration, a lot of dose outcome modeling. And then at the beginning, of course, it was a lot of associations and so on. And then I discovered causal inference, and it has completely revolutionized the way I think. And I'm really pushing that into my research. So what I'm doing, what I'm going to give in this talk today is I'm going to give you a little bit of introduction about how we can do, what is cancer treatment. So what is cancer radiotherapy, actually radiotherapy for treating cancer, and why it's actually a very nice like place where we can actually have actionable changes or interventions based on what we are going to learn from causal inference. And then I'm going to showcase some of the projects we have in our group, and that will be it. And then I have, of course, please do not wait until the end. If you want to ask me any question any moment, please do for it. Okay, so how can causal analysis help us improve radiation therapy for cancer? First, we need to talk about cancer, right? So we all know cancer is a disease that happens to many people. So it's estimated that 1 in 2 people will get any type of cancer during their lifetime. And cancer is simply when the cells start reproducing like crazy. Like they do not stop, they do not disappear, but they can grow. They create tumors and they spread uncontrollably around the whole body. And that is when we are talking about metastasized cancer. To be able to treat cancer, but of course, what we all know is that early stage is the best, but you can also treat it with different types of treatments: surgery, chemotherapy, radiation therapy, or radiotherapy, and normally a combination of these ones. And in particular, radiotherapy is used in around half of all cancer patients, all cancer treatments that we see in the world. So it's really one of these, they call it workhorses in cancer treatment. So just to know, in the UK, we have, like every single year, we have many cases. Many of them, like around a third, will not survive the first year. And then, so it's a lot of work that we need to be doing to improve treatment if we really, to meaningfully improve treatment for the future. So if we go and zoom in into radiotherapy, so what is radiotherapy? It's simply treating cancer with radiation, right? So we have ionizing radiation that is aimed at the body of the patient, and it is such that we give enough dose to the regions where there's cancer for those cells to die, to stop being there, but at the same time trying to avoid damage to healthy tissue. The key point with that is that the radiation is going to damage the cells, so the cell DNA, and cancer cells tend to be very bad at repairing themselves, because in a way you can think about those cells going in this crazy mode of reproduction, creating many, so they don't have enough time to reproduce, and therefore they die, and the body actually eliminates them. So then a key question here is how we are going to aim radiation. So I will show you how it is done right now. So what normally you have is a patient where we know that has cancer and has been decided to be treated with radiation. That will come and then will lie down in one of these machines that is called a CT scanner, a computer tomography scanner. And you can get images that are 3D images. And here I'm just showing you a little bit of an image. So there is a cut from the patient. If you cut it like this, it's a sagittal cut. And it's going to show all the anatomy of the patient inside. It's a 3D image, it's not a snapshot of the anatomy of the patient. In this image, that is a medical image, then you're able to identify the tumor. So for example, here, and that is actually very tricky. Normally, the doctors will not only rely on the image, but they will also rely on what they had with the patient. So they will come, they will touch the patients to know, okay, that the tumor is extending to this position, and then they will find that in the image and then delineate it or create that kind of a volume. Not only the tumor, but also the organs we know that are healthy, like for example, the brain. This is the brainstem, the spinal cord. This is the so pharyngeal constrictor muscles or a cavity. You will find all the regions that we need to try and spare, because if we put too much dose, they will stop working, and that means that the organ or the beads stop functioning. So you may end up curing the patient, but then the quality of their life after survival will be very impacted. So the next step is when you have the image, we have the contours of the tumor as well as the contour of the organs at risk. And that's how we call them the healthy tissues close by. Then we are planning the radiation, right? So the way to plan the radiation is aiming the radiation to where the tumor is. And then it's done. This is a very old picture, but it's still a very clear picture. So this is a linear accelerator. So that is the machine, sorry, this one is the linear accelerator. So this is the machine that is going to be treating the patient. The patient, you see, it has a little mask. This is for head and neck, and it's to be able to reproduce the position of the patient every single time. Then the machine goes on, it will open radiation. It can rotate around it. And by rotating and opening and closing, then you kind of paint those within the organ. So this is an example of how a plan can be delivered. So you see the regions that we want to treat are within this red contour. So there's a tumor. And then you see that it's a very red, very hot colors representing high doses of radiation. So this is how the treatments are planned. So we have the image, the geometry of the patient, and then we know how the radiation can be deposited, and we find the best way to open and close this kind of beams and rotate around it to be able to create the best dose distribution. In here, the key point is to be able to put a lot of tumor put a lot of radiation dose in the tumor while sparing the healthy tissue. And that is actually really a kind of a balancing task. It's always very tricky because if you put a lot of those, all the cancer cells will be dead, but so will all the organs together will be damaged. The cool thing about radiotherapy is that we have a lot of control, and I'm talking a lot about it. So this is an example of a head and neck case. I'm cutting it like axially, so around here. So this is at the base of the skull. Here is the back side of the teeth and the mandible. This is something called the parotid glands in the green colors. And this little bit here is called this is the swallowing muscle. And if you damage the swallowing muscle, people cannot swallow. And that's a very difficult complication. It's called dysphagia. And then you can see this is one plan, but we can also make this plan on which we can very nicely avoid this contour, this organ, to reduce the amount of dose. So if we know where we need to spare the dose, we have the tools to be able to dial in and out the amount of dose we're giving, and therefore we can actually purely, really directly impact treatment outcomes in radiotherapy. So that is more or less the background of radiotherapy. So that's what I was telling you. So the question is, how can causal analysis actually help us improve? Well, I have already kind of mentioned it. If we know a cause and effect relationship between radiation dose and treatments, then we can decide safe thresholds, right? So we can say if this, for example, this organ is receiving less than 20 gray, and that's the unit is gray, then we know that we are not going to trigger this side effect. Right? We can also talk about survival and after treatment and so on. It can also help us find the best way, the best treatments to be able to have the best outcome for patients, on which we are then talking about like individual estimation of outcomes. Sorry. And we can also combine different data from trials and real world data, which is something we are like, real keen on doing so in the future. So what I mentioned, I want to do some spotlight in some of the projects that we have. Going to start with one that I am leading, that is the part of a dose to a very small part of the brain and problem swallowing after radiotherapy. And I'm going to tell you about 2 projects that we are having right now with 2 PhD students. I put a little picture in there, and some work we did in the past with a master's student, and it's just published, which we are very happy about it. So let's talk about the first project, that is dose to the medulla oblongata. So it's a little piece of the brain, and dysphagia. So dysphagia, again, is problem swallowing. So normally when you're swallowing anything or when you're eating, there are many, many different muscles that move and contract and do stuff to be able to move the liquid from your mouth all the way to your stomach. And here is an example, right? So you have this water, the tongue moves, then this one closed, this little bit goes down to avoid the water going into the trachea. You know, sometimes when you drink water and goes through the back one, it's just that the water has gone through the wrong pipe. Let's call it like that, and it's called aspiration. So it is all the movement of all the different muscles, and of course, if the muscle stops working, That is what we know. If we damage some of these muscles, we know that dysphagia, so problem swallowing, will come after treatment. And then using some analysis that we are doing here in the group, that is called a voxel-wise analysis or voxel-based analysis, we also discovered that there was a big association between those to this little part in the brainstem. So this is the brain of the patient. Down here is the brainstem, and down here is a little piece called the medulla oblongata. And we saw that the dose that was associated with dysphagia. Of course, the question is that association just because of the way the dose is being given, or maybe because there's something related back down in a different anatomy, maybe it's a surrogate of dose to this little pit in the front. So there were many questions. And I remember when I was talking about this with the head and neck consultant I was working on this project, he's now in Canada, he actually told me to go back to my analysis because that doesn't make any sense. I was like, dose to the brain and dysphagia, that's not really, that doesn't count. That's not going okay. And then he actually went and talked with speech therapists, and then they mentioned that when people have a stroke in that part of the brain, in the brainstem, then they actually develop dysphagia. So that came back as that may have a bit of reality. And then we actually started looking at this with then a causal inference kind of framework. So we had this association, those to this little piece of the medulla oblongata and dysphagia. And then we actually went full blown and we made a DAC. So this is a set of experts. This is we had a consultants. So we have head and neck consultants, clinical oncologists, we had physicists, we have speech therapists, we had computer scientists and causal inference person. So like that was Matt Sperring. And we created this beautiful DAC. We have time, have many different things, and we actually were able to identify an instrumental variable as well as some variables we need to stop with the back door. And then we did the analysis, and actually the values of between these two, between the instrumental variable as well as the normal backdoor criteria, were not exactly the same, but they were in the same side. So both of them were either telling us more dose to the medulla oblongata is increasing the odds of failing a water test, or it's going to reduce the capability of patients eating normal food. So this is a different treatment, a different assessment, sorry, or it's going to actually impact quality of life of the patients. So we have 3 different measures of dysphagia, and we saw that using this DAC, we had actually very similar estimations of this causal effect on these patients. We had actually 114 patients data that we actually analyzed for these. Of course, the question that is always thrown up, and then I have always been asked about it, is like, if you have a bias panel, you are going to have a bias estimate because you're going to have a bias DAC. So what the heck? I mean, especially people from the US were like, I'm not so sure if I should believe that or not. So what we did is actually we repeated the whole DAC elicitation process with, so that was the UK, so this is the what you have already seen. And we repeated the elicitation process with some experts from the US. So again, we have clinical oncologists, we have physicists, we had speech and language therapists. They were key people to have because they had such a different insight than most of us. And on top of that, in the US, we also had some surgeons who came to the panel, because it seems to be that surgery also in the region can also affect swallowing problems, right? So it was important to have their expertise. And we had, of course, what was Matt as well as me driving the analysis. And then we had these 2 different DACs. And we did completely independent panels. So the only people that worked together was myself and Matt, so the causal inference expert, as well as me, a computer scientist, who were driving DAGIT just to be able to create the DAC. But we were letting really the experts put the different variables and the arcs and so on. So if you look at the DACs themselves, we see this is the one that has been created here in the UK. So it's the first DAC. It's relatively clean, I will say. It's simple. We have 28 variables, 62 arcs, which is not bad. And I'm sure you cannot see it, but please do use the QR code if you want to see it. And if we go and look at the data from the US, it was very different kind of reality, what they were thinking about. So we had 53 variables, 126 arcs. There were factors that we have never even discussed in the UK side. It was like thickness of saliva. It was thickness of the muscle. There was the different types of surgery will have also different effects on dysphagia. And all of these came together. And actually the variables we needed to adjust for were not exactly the same, but were very similar in the sense of they were looking at tumor location, nodal location, tumor dose, distance to the medulla oblongata, pretty much. So we characterized them all, and then we were able to find the average causal effect estimates. And then we see that both of them are actually, again, for the different measures. So water test, which is very, very objective measure. You just take, just simply take water, you drink the water, and if you can drink it without no problem, you pass. If you don't drink it, then you fail. You have that one in here. So it was, again, the odd ratios are very similar. This is the one about the type of food the patients are comfortable eating. So again, a more dose means that the patients are comfortable eating with only food that's a lot more soft than they used to before. And then that is the quality of life. So then there were questions about, for example, patients not being comfortable eating anymore in restaurants or not allowing other people to cook for them because they will not be able to eat. So we saw that even though we had such a different kind of assumptions behind the dysphagia, what was creating dysphagia, where the dose was coming from, and all the stuff, we see that the estimates are actually very consistent, and that has actually given us a lot of confidence that this is a real cause effect estimation. And we're now doing this analysis with an extended cohort. So now we're using not only a US DAC, but also a US data set of 180 patients. And well, I will tell you how it goes later on when we talk again. So this is a very cool, I really find it very, very, I found using DAC such a powerful tool to be able to discuss the assumptions we have and the realities and see what is the impact of that on the estimate. So that is one of the projects that I wanted to showcase. The second one is one by one of my PhD students, that is Miren. So I co-supervise her with some people here in Manchester. And we're actually looking at using DAX again as a tool to be able to revisit published analysis, right? So there is a lot of information, or there's a couple of papers that have been looking at those. So this is now this is a long case. So this is the lung, you can see it here. You can see the heart in the side here, and you have the other lung, and we're cutting the patient, if you could say, a corona. So like from one side to the other like this. And then we found that the region here, using the same kind of spatial analysis, we found a region in the base of the heart that was associated with early mortality. So people who had higher doses in that region were dying. And that actually everybody in radiation oncology always thought the heart is not radiosensitive. We don't have to worry about the heart in these kind of cases. And we actually came and said, okay, that's not the case. So what we did, what Miren has done is fantastic work. She has done, and she went and she created a big master DAC on which you can actually set up all these kind of assumptions of those to the heart and survival. And then based on these, and then with some small changes, so based on this, you can create the minimal adjustment set. And with some adjustment for practice differences, then she can actually go back into the papers that have looked into this effect and see, okay, these are the variables that are being assessed in the part of the analysis. This is the minimal adjustment set, again, including some practice variation, and then being able to describe, okay, this study has a bias estimate or doesn't have a bias estimate. So it's actually very, again, I keep on thinking about DAX being such a powerful tool to not only evaluate the current assumptions that we have, but also the assumptions that we have had in the past, and be able to look at the published literature with a causal framework, which is very, very powerful. Miren has, so she actually presented part of this work in ESTRO, so that is the largest radiotherapy conference in Europe. That was in May, so it is very, very fresh out of the press. And here is a DOI in case you want to actually look at the abstract. The second project that I would like to actually give some showcase here is one by Charlie Kunif, that is looking at the effect of combining chemotherapy and radiotherapy in patients with advanced lung cancer. So you remember at the beginning when I was talking about treating cancer can be done with surgery, chemo, and radiotherapy. And chemotherapy and radiotherapy are they're normally very much used together as a team. But there are differences whether you give the patient, whether you give the chemotherapy before or at the same time as radiotherapy. And the idea is also that, or the assumption that has always been, is that patients that are very, very frail will not be fit enough to have the combined treatment. So the question was, so do we do chemotherapy and then radiotherapy or simultaneously? And because in theory, when you do it at the same time, has been demonstrated in different trials, clinical trials, that the outcomes are better. But often frail patients are not offered this because of what I just mentioned, not being fit to finish the chemotherapy or the radiotherapy side of the treatment. So Charlie has done fantastic. She is actually working with working with Protect, that has been a scheme done proposed in the past by Wouter van Amsterdam. So she actually took that kind of methodology and she put it pretty much into our analysis, and she was able to find individualized treatment effect estimates for a patient cohort that we have. And then if you're in one, is simply like either concurrent or sequential radiotherapy are giving you the same kind of outcome. If it is in the less than one, that means concurrent is better. If it is more than one, it simply means that sequential is better. And what you can see in this graph is the lines. Each of the lines is one patient. The color is telling you what the patient has gotten, whether they got concurrent or sequential. And you see there's a lot of sequential because these patients tend to be relatively frail. But if you put them together, you see that in reality, if you look at the average, that is the blue one, you see that concurrent is still, in theory, better for this patient. Of course, there's the question about being aged and frail or not. So when Charlie did a sub-analysis and then she divided, so she did an analysis for the whole cohort. That is the one in here. So you see that it is closer to the one. So it is closer to, well, both of them are giving you pretty much the same kind of outcome. But if people are fit and young, having concurrent is being shown as being more beneficial than for the patients that are old and frail. So this is a very cool show how we are using, again, causal inference estimations to be able to start looking at individualized cases. So we have demonstrated that causal analysis can provide a more credible estimate than the standard multivariable analysis. So that is, if you compare, going back, if you compare this little guy here, is all the way here and saying everybody should get concurrent. But when you start looking at it, it's not really everybody. It depends on the patient's characteristics. We can see different individual estimates. And of course, what we also already knew is that we can see the differences for age and frailty in the populations of the estimates. And that is coming back in the numbers, which is, I find it super cool. This work was also presented in ESTRO just, again, in May, and the DOI is here. And please let me know if you want to contact them. They are super cool PhD students working with us at the moment. But we have up to now looked at patient as a single unit, right? So the patient as such has the treatment. But you can see actually that the dose distribution or the treatment is very much localized. We have high doses in some locations. That means that the organs close to that locations are going to be affected by the doses, but organs far away, they may not be. Even within a single organ, we can have regions that are with high doses while other ones are not. And then the question now is, instead of thinking of the unit being a person, what if we thought about the unit being a piece of the anatomy, a little part of the anatomy? The problem there is that we know that all the dose distributions are correlated. So if I am in this position, the point next to it is likely to have a value that is very close to it, because those has to travel from outside into the patients into the body of the patient. So there's a correlation, a collinearity actually inside, which will break several assumptions of causal inference. And we also know that some of the organs, if you damage a small part of the organ, the functionality of the whole organ will be impacted. So again, there are a couple of assumptions, especially in the no interference, that can be actually not valid when you're looking at the unit as a small anatomy of the patient. But anyhow, one of the things we want to really push forward is to be able to do a spatial causal inference, so to be able to examine the local effect of those and the outcomes. And this is some work that Alex here in the picture did during his master's, and it just published, like, look at the date, 2nd of June, 2025. And what we did is a study, it's a simulation study on which we had like idealized kind of case. So this is our patient, it's a beautiful cube. We have a tumor anywhere else, anywhere inside their body, so the tumor can be moved anywhere. And we have an organ here, and we have a region that we know that we are trying to spare, trying to duplicate that. There were many different simulations. So we simulated the noise, independent noise, because it can be, for example, when the patients are coming for treatment, they can have a cold, and then bits of the anatomies are full or empty. Their stomachs can be full and empty, stuff like that. They can also have weight loss. So, for example, all the anatomies changing at the same time. So there can be differences in the dose from random components, from kind of systematic components. And this is also when if you have an error, for example. So what we did is we simply simulated very different kind of noises, and we created a kind of a delivered dose distribution. So we have blood dose distribution, a delivered dose distribution, and based on a DAC that Alex created himself, based on the different kind of noises and elements, and then he actually created. So this is going to be my estimation. So I'm going to create, this is the region that it is connected to a simulated outcome, and then he proposed to use a causal adaptive lasso with a sparsity, and he has demonstrated that using those kind of this kind of methodology, you can actually you are able to reconstruct the original cause and effect simulation that he has put on, which is very exciting. There are still many, so that we have now a causal tool to be able to estimate local effects of those outcomes. This is very exciting. It's very nice piece of work. There is still some limitations, and we know that resolution, for example, is a key component that we need to be careful to do that. Something that was very clear is that the sparsity is required because of what we're talking collinearity and associations. So yeah, correlations between the neighboring vectors, and there's still a lot more to be done. So this is something that I think it is going to become super hot. I mean, people in radiotherapy are starting to really be interested in causal inference at the moment, and I will tell you maybe a little bit about it at the end. So to conclude for my presentation, causal analysis, I really believe is going to revolutionize the way we study dose and side effects. Because the key point is that we all want to be able to know which part of the anatomy we need to spare to keep the patient healthy and happy after they have survived cancer. That is a key point. We are still. I keep on talking about DAG being this amazing tool to be able to put down our assumptions, to have more transparent science, and also to be able to, that would allow us to also go and revisit previous findings to see how much of associations, bias are there inside, and then to be able to reanalyze the data which is a paper which is now submitted, will allow us to challenge assumptions in the field. For example, what we are talking about, the brainstem, so the little part of the brain being associated with dysphagia that was seen as no, well, that doesn't make any sense. Well, now we are showing it does make sense. That is where the swallowing centers are located. So pretty much the part of the brain that tells which muscle to move when to be able to swallow. So if they get out of control, that's when you have problem swallowing. So again, we're challenging assumptions in the field, and We still need to do a lot of more work to enable local effects, but we are we already see the potential of that with the paper I just described. We, of course, the key point here is that we want to have better support for decision-making processes in radiotherapy. And just what I was mentioning before, radiotherapy is really getting into, it's very interesting causal analysis. We are, for example, running at the moment a causal elicitation of osteobrionecrosis with some people with collaborators in Newcastle, in Germany, in the Netherlands, in Denmark, the US. So this is the amount of experts keen on just sitting down and, okay, let's put this on paper to better get an estimation of the causal effect of those and osteobrionecrosis, that is when the bone completely dies and breaks down, and it's a devastating side effect, as well as other things like lymphopenia and lymphocytes that is connected to the power of the body to be able to fight infections. And with this, I want to say thank you. So not only to the CHAI group, but also to the CHAI people in the university, but also beyond, but also to my my radiotherapy group here at the University of Manchester. And I think with these, I want to say thank you very much for your attention. And I will stop sharing now.
Thank you for your presentation. It was very informative and amazing. And I don't know, maybe we should proceed to questions from the audience.
Yeah.
Anyone, feel free to unmute and ask a question, please. Yes, I can see Santos.
Question? Santos.
Hi, Eliana. Nice to see you.
Nice to see you too.
Very nice presentation, actually, and very thought-provoking. And it's a perfect example of how causal analysis can come into the image space, right? Of how you might think about what are you doing in the image, which in reality, you're not doing it in the image, you're doing it with an external process that affects the image and then and so on. It's more a bit provocative in the sense of what you said in your last slide about future work. And CHAI is very much interested in seeing what current methods do not address, like from a causal perspective, where the current gaps exist as a way to do what you want to do better, right? So is there any hint you can give us of, how we should be doing better our job as a way to make your use of the causal AI and causal inference better?
Yeah, no, I think it's, I've been trying to dive into that as well right now. So the spatial side of it, to be able to, if you have an object, like a voxel in the image that is affected, its outcome will be affected by another voxel next to it because they belong to the same organ. But there's going to be a, what is the name? The no interference assumption is broken.
Mm-hmm.
So I've been really I've been looking into a spatial causal inference because of that, and also Mirren is working into that at the moment. But the key point that I will really be keen to try and play with is spatio-temporal causal inference. So which I'm going to be hopefully working on. I will be reaching to you very soon.
Yeah, I think this is something that is intriguing us in many different ways.
Yes.
We're being intrigued in these things, not in such difficult tasks as yours, but simpler, I would call it, tasks. But I do agree with you, there is a lot of method gaps there. Not only about how do you take a method and you apply it, but like how do you create such a spatio-temporal inference way to know what you can intervene on and when. I think that's very, very intriguing. I'm definitely looking forward to conversations jointly with Matt and your team as well. If there is anything we can do, we can arrange. Very interesting. Thank you, Eliana. It was very myself coming from medical imaging as well and medical image analysis, to see kind of these things blend so well is very eye-opening. Eye-opening. Thank you.
And I really mean the part about, I've been talking, I have a presentation in Estro in May, in which I presented this part of the two panels. And one of the things I keep on saying is that we need to move away from correlations and associations if we really want to improve treatment patients. Because we cannot say, okay, this region, this organ is kind of associated, so I'm going to spare it. So let's dose a lot of resources going into that. And still you see trials that have demonstrated that not if you only spare that part is not enough. You still see the outcomes coming, like xerostomia, that is a dry mouth being there. So there's a very cool a trial article in France on which they really made the possible to avoid the parotid glands, but these patients who were going into the test trial, and so the arm were having worse dry mouth than the other ones, which is very interesting because it's contradictory. So I think in these cases, causal inference will be beautiful to be able to really examine what is the local effect. So yeah, I'm very, very keen on.
No. Is that trial the one also with Therapanasia involved of Nikos
I don't
Paragios?
think so. I don't.
Okay.
No.
I mean,
It's a
I think
different
this is a conversation we need to have offline. There are some interesting things to explore as well there. You know.
Yeah, I'm again keen to have a talk.
Definitely.
Yes.
No, thank you. I'm not going to monopolize the convo, so I'll
Sorry. Yes, absolutely.
I'll shut up. Okay.
Thank you very much, Soto. Nice to see you in real. Well, in semi-real.
Two dimensions.
Yeah, exactly. Any other question, guys? I mean, I may not have all the answers, but I'm happy to try.
Well, if nobody's asking, maybe I can ask a question myself. Hi, my name is Ricardo, also one of the colleagues of Chai.
Yeah.
Thank you very much for your talk, Eliana. It's very good. I was wondering when you talk about spatial relations, but there's some notions of representation of the data that can be relevant in levels of resolution, or even if you represent, I don't know, locations by some sort of topographical network. How does it reflect in application?
Yeah, no, so there are some, so not for causal inference, but I'm aware for some topographical representation of different locations of the anatomy, but more in the side of a tumor. When you have a tumor in the head and neck, for example, they tend to, when they start moving around, so metastasizing, they have a very defined path that following some lymph nodes. And then there is a very cool work from Unkelbach, that's a person, yes, on which they actually represented the lymph nodes, the primary tumor, the location, and then they are able to model based on biopsies as well as imaging outcomes, how is the most likely path of extension. And that is very important because when you are treating these cases, you treat the tumor and then you also treat the lymph nodes you expect to be with already affected by cancer. So it's not only what you see, but also what you, so they are very important because that will mean either you treat the whole neck, like I'm really talking about from here all the way down here, versus treating this piece of the neck. So it's huge importance in that. So that is the part on which they put that was more like upscale, like organs connected, making a graph and keeping that graph in. I think it was using MCC, I believe. I'm not so sure. I need to remember that exactly what they did. But in general, we have all the patients are also represented in a geometrical way. So I was showing the contours. So you can actually have the 3D dimension of the patient, which you have the body, you have this, and the organs inside it. So that is very easy to get for all the patients. And you can have summaries of the doses or summaries of the CT, for example, or any kind of characteristic you want per organ, and then connect that in a graph and then play with it if you want to keep it high level. Something else that we do in our group is instead of doing that, we keep the image and we actually we have a reference patient, a reference anatomy, and we use image registration to bring all the treatment doses into the same frame, to the same frame of reference. And then like that, you can actually analyze point by point. So like the tip of the nose, the maxillar something. You can analyze every single beat at this moment for associations, and that's what we are moving into the causal side. So instead of doing associations, we want to do causal analysis. But that is where I was just saying to Sotiris, where if you are within an organ, you have to keep that in mind, because, for example, in the spinal cord, if you damage a very small piece, all the spinal cord is working, because it's what we call a serial organ. So you need to incorporate this kind of knowledge in the. So it is very. I think it's a very exciting, but it's a lot of work to be done.
All right, thank you.
I'm sorry, I keep on talking. I get
And we
interested.
came to lesson 2, right? Thank you very much.
Yeah. Thank you, Ricardo, for the question. We have a message from Belgium telling us that the next speaker for welcoming next week, 17th of June, Krishnan Ramai and Professor Rema Patman. So, yes.
Oh, that's great. Are there any other questions?
I have a question.
Hello.
Hi. I'm Nick Longford. I'm retired or semi-retired. I'm interested in causal inference in general, and my interest is in assessment of uncertainty.
Oh.
So you have all these DAGs, and my view on them is that most of the variables that are recorded are proxies, are surrogates for something that we don't quite understand.
Yes, absolutely.
Yeah, and because sort of we are tied by the variables are what we can observe. Now, how can you get any insight into, suppose there is a factor that we fail to observe? What kind of influence it might have on the analysis?
Yeah. So when I'm eliciting the DAG, I on purpose do not keep the discussion on the things we have recorded, because exactly what you're saying, because there are things that the doctors know. Well, I know if the patient is fit, they have a better chance. But then how do you actually look at fitness? Is it because of something called performance status? Is it something like a blood pressure? Is it muscular, blah, blah, blah? So there are very different ways in which you could proxy patient fitness, right? But the doctors know if my patient is fit, I know they're going to do much better than if my patient is frail. So when I'm creating, and again, maybe I'm not a consumer inference expert just yet, but I am doing my very best to train myself into this. I allow variables that are not quantified, and they're actually still very vague in the DAP. Because once you have it there, you start creating the connections. And sometimes they are the key variable, or maybe one upstream can be controlled that it is now measured. So I fully agree with you that we sometimes we don't know what we don't know, right? So there will be maybe aspects that we have no idea that are there, and we cannot have it in there. But I think, and that is the beauty of DAX, at least how I see the DAX, that once you have it in front of you and you look at it, then you say, okay, these guys are assuming this. And then you could, for example, say, you are forgetting this variable, and then you can bring it up, and then you could, for example, reanalyze the data with a new DAC, with a new variable, whether it's important or not, that is something else. So I see it more, maybe idealistic, maybe a little bit naive, but I see it as a fantastically powerful tool to be able to have these kind of assumptions inside. So in the part of the uncertainty, but that's something that we were discussing actually, I think yesterday in a different context. When you have a variable that is very important, that is part of the ones you need to adjust for your analysis, and if you don't have anything recorded about it, so what you can actually do is to create, you know that your estimations are going to be biased because of that variable, and then you can do a sensitivity analysis to see what will happen if my patients are all healthy what will happen if all of them are frail. And you can also do some kind of Monte Carlo simulation to be able to see how your estimation actually is stable or not. But that is how I see it. And I see Charlie's coming up, which is great. Do you want to discuss, add something, Charlie?
Yeah.
Perfect.
So that was the purpose of the Protect that Eliana was talking about earlier. So that's my PhD project. The aim of that modeling is to be able to estimate what patient fitness as seen by the clinician is when making those treatment decisions. So the variables we have, like performance status, frailty score, and comorbidity score, don't capture what the clinician actually uses in those sessions. So when how well the patient stands up and sits down, do they get out of breath walking down the corridor? How well are they able to hold up a conversation? Those things are very informative to which treatment they're going to prescribe. So we, for Protect, used the variables we could measure in order to model what patient fitness was in a kind of Bayesian latent factor modeling setting. And in addition to that, yeah, we've also done a sensitivity analysis by including another unobserved confounder and being able to vary its strengths based on what we thought what we'd measured from our latent variable, so that we had kind of a scale to base the unobserved confounding effect on. Yeah.
I don't know, Nicholas, if that answers the question a little bit. I mean, of course, it's a whole field, I think, the part of uncertainty estimations and so on. But this is how we see it at this point. It might be that when we become wiser and older, then we say, okay, we need to change the methodology in a different way. But that is how we are right now tackling it. Thank you, Charlie.
Okay, thank you very much. If I can ask another question, which sort of sounds like unrelated, but in fact it is related, and that is this: the clinicians with whom you work, they are highly qualified people, yeah. But my experience from another field is that still there are vast disagreements in how they operate. Now, what can causal analysis do to arbitrate, at least partially, in sort of helping them to learn which of the sort of alternative practices are superior?
Oh, Charlie, that's a difficult question, right?
Well, you don't have to answer it. I just leave it with you.
I think it's a very good. It's very thought-provoking, I will say, and I think that will be. I mean, opening the discussion with the clinicians and telling them, well, you know, the thing that you thought is real is not. Is difficult, but I think it has to be done, especially moving forward. But yeah, I really don't know, and I don't have an answer for that at the moment. I mean, to be able to make things more consistent and more like based in real evidence.
You know, the non-answer I have is that you could conduct a clinical trial where you do alternative sort of so for simplicity, just assume that there are two alternatives and you want to arbitrate. Yeah. Now, the causal inference, or sort of in causal inference, at least in the potential outcomes framework, you always think about what would be clinical trial that's emulated by the observational data.
Yeah.
Yeah.
Yeah. Yeah.
And so sort of, you know, this I believe is something very appealing to the clinical community. They understand clinical trial, and they trust in their outcomes.
Yeah.
Yeah. Okay, I'll stop there.
Yeah. No, the target trial.
Yeah.
Yeah, Charlie.
The target trial framework pretty much runs off of that formulation. So you set out what you would ideally do for a clinical trial, and that would be a conversation that would be very useful to have with the clinicians who set out clinical trials. So if you had the ideal scenario and you could include all of the patients that this would possibly affect. And then you kind of break that down into, okay, so what was the inclusion criteria for that clinical trial? So I will apply the same inclusion criteria to my observational data, and kind of work from there. And as for like validation of things, various questions have already seen randomized controlled trials. So the sequential versus concurrent chemoradiotherapy, that did have clinical trials in the late 90s, early 2000s, and meta-analyses have been done for those, but they had very strong inclusion criteria, as randomized control trials do. But one method of validating, but gaining trust in, say, the model that I've built would be to, if we could get a hold of that randomized data in order to run the model on all of those patients to see what like the model thinks would have been the best treatment. And then we can compare the two groups, the ones where the randomized treatment agrees with what the model would have predicted was best for that patient, and another group where they disagreed. And ideally there would be, well, if the model worked, some form of outcome discrepancy between the two, which could also improve trust in models.
Yeah.
From the clinician's
Thank you.
perspective.
That is a
Thank you.
very interesting topic, and I'm also a big fan of uncertainty estimation, and I did a lot of that, so it can spark like
Yeah.
a lot of beautiful conversations. But I'm afraid you have run out of time. I would like to thanks again our speaker, Eliana, for the amazing talk. And of course, please check out the Data Science for Health Equity, the website and the newsletter. And speaking of which, please check out our newsletter as well, because we do have one ourselves. And that's the way I think that you will be updating for the next seminar, which will be up in August. So
Perfect.
thank you everyone for joining in, and hope to see you again in those beautiful sessions and seminars.
And thank you everybody for your attention and for the questions. Panels, thank you. Nice meeting you.
Thank you. Thank you, everyone. Oh.